All right, well, it's 5 o'clock.
We'll get started.
Yeah.
All right. Hello, everyone. Thank you for coming this evening. My name is Jenny Kale, and I'm an emergency medicine pharmacist at Massachusetts General Hospital up in Boston. And I'll be speaking alongside Rachel Skanes, who is an assistant professor at the University of Alabama at Birmingham and works as an emergency medicine physician at Birmingham VA Medical Center. And today we'll be talking about the appropriate geriatric emergency medication recommendations. Neither myself nor Rachel have any financial conflicts to disclose about the topic today. However, Rachel does have some wonderful research funding that is listed below. Objectives are listed on the slide here. I won't go through them. So I don't think we can talk about older adults and the aging process without talking about how we become more vulnerable as we age. We have more illness and injury. We become less mobile. We have less sort of reserve capacity due to physiologic changes. Our cognition declines, and sometimes our mood becomes quite dysregulated. But when we talk about why older adults are more vulnerable to certain medications, their therapeutic effect, their safety profiles, us pharmacists, and hopefully a lot of the physicians out there, also talk about differences in the pharmacokinetics and pharmacodynamics that occur with aging. And so when we talk about pharmacokinetics, this is really sort of what our body does to the drug. So we think about absorption, distribution, metabolism, elimination. So the absorption of oral medications as we age doesn't change a whole lot. Sometimes our transdermal absorption does, but we really think more about distribution, metabolism, and elimination. So for distribution, as we age, we have more fat, less water, and less muscle mass. And so this changes lipophilic medications because they're distributed more widely throughout the body, and we sort of hang on to them longer. So we have increased exposure, potentially higher level of lipophilic drugs. And it's the opposite for hydrophilic drugs, so potentially diminished exposure to those. And then moving on to metabolism and elimination. So as we age, we have less functional hepatocytes and nephrons, and so certain medications that are typically metabolized that way aren't metabolized as quickly. And so again, we have higher concentrations, prolonged effect. Same with elimination. We have decreased blood flow to our liver and kidneys as we age. So again, this is really why we tend to see a higher therapeutic effect and potentially more toxicity. And then when we talk about pharmacodynamics, this is more what the medication does to us. And I chose a few different medication classes that we typically use to treat agitation in our patients. And I did this because this will come into play for some of our patient cases later on. But specifically for our benzodiazepines, as we age, we become more sensitive to their effects because we actually have structural changes to the GABA receptor and composition changes that make us more sensitive and have a greater therapeutic effect. And then as far as antipsychotics, as we age, we have at lower levels of dopamine in our central nervous system. So when we give these patients medications that further block the dopamine effect, that's why they're at increased risk of these unwanted movement disorders, or EPS, with our antipsychotics, particularly our first generation, but also a certain degree our second generation.
So now I'm going to talk about some practice-changing advances in prescribing for geriatric ED patients. There was a recent article in ClinStar by Goldberg et al. That describes some medication safety programs in the ED. And the first is leveraging the EHR. So there's been a few articles on having order sets developed to aid and assist ED prescribers in selecting safer medications and appropriate dosing and recommendations for patients being discharged. The second is leveraging prescriber feedback, mostly through audits or dashboards, but you can also use ED pharmacists to send the notes to prescribers for recommending changes in medications. The third is leveraging experts, so this is mostly ED pharmacists or pharmacy techs to identify and suggest medication changes that led to the ED visit or adverse event. And this is usually using the AGES-Beers criteria or the start-stop criteria. And the fourth is education, so either residency or faculty education through didactics and safer prescribing practices, or having the ED pharmacists have education real time at the bedside. But the first thing we need to do is identify older adults at high risk of medication adverse outcomes. A popular tool that is used in a lot of geriatric EDs in triage is the ISAR, which stands for Identification of Seniors at Risk. It's a short 6-item screener, and a score of 2 or more may indicate that an older adult is at high risk of adverse outcomes if admitted to the hospital. So we were playing around with this earlier, so there's already been some submitted. But we're going to use Poll Everywhere for a few polls throughout the didactic. So if everyone would please go to the web at pollev.com/RachelSkanes977, or you can text Rachel Skanes 977 to 37607. And unfortunately, it's cut off, but A is yes on the left and B is no. So I'll give everybody about a minute or so to kind of submit if you guys have any standardized processes to identify older patients at high risk of medication adverse outcomes, such as the ISAR in your EDs. And for the UAB folks, we do. Which may be some biasy. All right, so it looks like about a 60-40 split so far. Has everyone had a chance to vote? Okay, we'll move on. So we're going to talk about some patient cases and medication safety. So the first one's an 81-year-old female that has a history of hypertension, hyperlipidemia, coronary artery disease, heart failure, that was recently discharged from the hospital to a skilled nursing facility 1 week ago for a heart failure exacerbation, representing to the ED, this time for altered mental status. Vitals are largely within normal limits, except heart rate is tachycardic at 116. Exam, she is alert but confused. She has difficulty following simple commands, but she doesn't have any focal neurodeficits. She's tachycardic, but otherwise heart and lungs are clear. Abdomen, the bladder is distended with mild suprapubic tenderness, and she has 1+ pitting peripheral edema that's symmetric. So what would we do for this patient? So the Geriatric ED Guidelines currently recommend that all patients 65 or older that present to the ED, regardless of chief complaint, but particularly for altered mental status or confusion, get a medication review. And this can either be performed by a pharmacy team, consulting and working with a multidisciplinary team, so having a geriatrician consult in the ED, or leveraging computerized clinical decision support tools such as order sets, EHR alerts, or order entry. A positive medication review screen is defined by polypharmacy, so more than 5 medications, or high-risk medications, and that can be identified using either the AGS Beers criteria or start-stop or any other criteria or list for high-risk medications. Then if the patient's admitted, usually the note of the medication review and recommendations are sent to the inpatient team to review, and if the patient's discharged, the recommendations such as deprescribing is sent to the primary care physician. And it's recommended that this is done annually. So let's talk a little bit more about the American Geriatrics Society Beers criteria. This is a clinical tool that ED clinicians can use to identify potentially inappropriate medications for older adults in the ED. It was recently updated in 2023. It's a very long list, and usually Table 1 is what's most referred to, and that gives a list of about 35 medication classes of PIMs to avoid prescribing and administering to older adults. So we used the AGS Beers criteria and did a medication review with our ED pharmacist for this patient presenting with altered mental status. And we found that she's on Lasix, amlodipine, a statin, aspirin, and recently prescribed oxybutynin after she was discharged from the hospital. And this is what's known as the prescribing cascade. So a prescribing cascade is utilizing other medications to treat adverse drug reactions that puts the patients at further risk of harm. So in our patient example, she was on amlodipine for hypertension. She developed edema, which may have been confused for a heart failure exacerbation. She was prescribed Lasix, which led to incontinence, and so then she was prescribed oxybutynin, which led to acute urinary retention. And now she has altered mental status from the anticholinergic and the acute retention. And you can see that the cycle can go on and on and on in older patients, leading to more polypharmacy, which is really emphasizing the importance of deprescribing and doing a medication review on older patients, particularly presenting with altered mental status. So one medication safety improvement program that was initially developed in the VA system as a QI project is EQUIPPED. So EQUIPPED is enhancing quality of prescribing practices for older adults discharged from the ED. It's a clinical decision support that has three components of provider education, prescribing order sets, and tools that have audit and providing provider feedback through one-to-one academic detailing. And it has been shown to be sustainable and effective at reducing PIM prescriptions from the ED across multiple settings, including academic and the VA systems. Another tool that was recently developed is the first ever Geriatric Emergency Medicine Medication Safety Recommendations, or GEMS RX. Using the modified Delphi development, they developed a high-risk prescription list for older ED patients discharged from the ED. So Table 3 has 8 medication categories and provides alternatives and exclusions for high-risk medications included in the GEMS RX high-risk prescription list for avoidance among older adults at ED discharge. And this is a tool that is now specific to the ED that can be used to aid medication safety for older adults being discharged. Now we're going to focus specifically on agitation, which is a very common presentation for older patients in the ED. And the most common etiologies for agitation are delirium, pain, and dementia, and those are very difficult sometimes to tease out in older patients. One tool that's been developed is the ADEPT tool that was specific for ED providers to aid providers and patients presenting with confusion and agitation in the ED. And so ADEPT stands for Assess, Diagnose, Evaluate, Prevent, and Treat. And it's available as a bedside tool in the EM POC app and is available to all ACEP members and really walks you through how to assess and diagnose and treat patients with agitation in the ED. Another thing that ED providers need to do is identify early delirium in the ED. There's been over 25 delirium screening assessments described in the literature, and a very common one that's used is a two-step screening process. So the delirium triage screen, or the DTS, can be used in triage and is a sensitive screening tool to rule out delirium. If the DTS is positive, though, usually the nurses go on to perform a more specific delirium test to rule in delirium. So the next question we have for Poll Everywhere is, does your ED have delirium screening for older adults embedded into your care process, such as DTS and triage? And again, sorry, A is yes and B is no, if you're using the texting. So it looks like so far about 75% do not have any type of delirium, or about 2/3 don't have any delirium screening processes in their ED. It's really important because it goes unrecognized and missed in up to 80% of ED providers, and is really associated with higher mortality and increased length of stay and increased hospital costs and functional decline. So the geriatric ED programs are really emphasizing early detection and screening for delirium in the ED, which can also aid in medication safety. I'm going to pass it back to Jenny.
All right. So this is not just a shameless plug for myself and Dr. Kennedy, but this flowchart is a very helpful resource to walk through kind of initial empiric questions of why your patient might be presenting with agitation, and then what is the most appropriate treatment based on the likely cause, as well as different past medical history. I'm not going to walk us through this right now because the key points I will be discussing in the next few slides. But the first question is whether or not your patient might be presenting with a painful condition. We all know that geriatric patients often cannot express pain the way that our younger patients can. So really doing a good physical assessment, getting that past kind of history of why they're presenting is very helpful in that initial question. So when we're treating pain in our geriatric patients, as with any medication, we think about starting low, going slow, right? The lowest effective dose. So for mild to moderate pain, typically acetaminophen NSAIDs when appropriate. I always recommend scheduling them around the clock. We know our ED nurses are very busy. We don't want to miss those doses later in the evening or early in the morning and sort of get behind that pain. More moderate pain, low-dose oxycodone is typically our recommended agent, and then if a parenteral opioid is needed, we usually reach for hydromorphone, as it is the safest option in any sort of like renal dysfunction. But again, start low, go slow. If pain is most likely not the cause of the agitation, then we start thinking about our antipsychotic agents. So we have our first generation antipsychotics, for which we typically use the high potency class. So our haloperidol, droperidol, these agents work by being potent D2 or dopamine receptor antagonists. And as I was stating earlier, because as we age, we have decreased levels of dopamine in our central nervous system, these agents, due to their high potency dopamine blockade, can cause those unwanted movement disorders. And then our second generation antipsychotics, being olanzapine, risperidone, ziprasidone, and quetiapine, are also D2 receptor antagonists, but to a lesser extent than our first generation antipsychotics, but they do have sort of diverse receptor binding profiles at other receptors. But as far as dopamine, risperidone does have the highest blockade of our second generation, and then quetiapine has the least, and this will come into play when we talk about different patients and medication selection. And I just wanted to note, because sometimes we see more sedation, more prolonged sedation with olanzapine, and that's because it actually works at the histamine receptor and is a histamine blocker. So that's why. And then our last assessment question. So patient case 1, this was our patient that kind of went through that prescribing cascade and presented with agitation, most likely due to delirium. Which antipsychotic would you order for the treatment of agitation? Who picked what? Okay, so it looks like the majority of you picked none of the above, so very curious as to what your selection would be. But of the options, olanzapine oral was the most common, and we'll kind of talk about why, or why maybe not, that was the correct choice. So talking about the treatment of agitation with delirium. So we typically think of delirium as being a state in which you have excess dopamine sort of neurotransmission, and that leads to the psychosis, the agitation, sort of the paranoia that these patients can experience. And so the first step is to avoid giving medications that have deliriogenic properties. So that would, in this case, be like our benzodiazepines, olanzapine, because it is a histamine receptor blocker. Quetiapine does typically above doses of greater than 100 milligrams. And then diphenhydramine and benztropine we should avoid, and we know that sometimes those are added to our concoction of medications. So because we think a lot of the times delirium is due to excess dopamine, using a potent dopamine blocker in this situation does make sense. And so as I said previously, for oral options, risperidone, our second generation antipsychotic, does have the highest dopamine blockade, so that's recommended. And then if you do need an IV or IM option, haloperidol or droperidol, one of our first generation antipsychotics, this is really kind of the one situation where they are recommended in our older adults. So moving on to our second patient case, this is a 78-year-old male with a past medical history of Parkinson's disease, dementia, and hypertension. He presents to the emergency department with his family for increased agitation and behavioral disturbance. His vital signs are all within normal limits. He is very agitated. He's pulling at his IVs. He's trying to get out of bed. He doesn't have any focal neurodeficits, and his cranial nerves are intact. And he does, at baseline, sort of have this shuffled and wide-based gait. So moving from sort of delirium to dementia and talking about appropriate treatment of agitation if the most likely cause is dementia. In this case, our first generation antipsychotics are not recommended because studies have shown that they tend to help with the aggression, but not really that underlying agitated state. Again, there's really no physiologic reason to give them benzodiazepines, and again, it can lead to delirium. So in this case, risperidone remains the recommended oral option, but for intravenous, because we don't need that really potent dopamine blockade, and our first generation antipsychotics do have that increased risk of movement disorders, we do move to our second generation antipsychotic olanzapine as the recommended agent. However, this changes a bit if your patient does, as our patient does, have underlying Parkinson's disease or if their dementia is Lewy body dementia, because they do have the underlying movement disorders. And so we really want to avoid as much dopamine blockade with our medications as possible. And so in this case, quetiapine, as I stated previously, has the lowest affinity for the dopamine receptor, is the recommended oral agent. But I do want to preface that if your patient, if you think that they do have an underlying sort of psychiatric reason, you do need to use a high dose of quetiapine, typically above like 200 milligrams to get that antipsychotic effects, versus the 25, the 50 milligrams we're using is really just sedating the patient. So keep that in mind when you're kind of selecting your agent. And then if your patient can't take oral medications, this is really the one scenario where low-dose benzodiazepines are recommended to really try and avoid that dopamine blockade. Now, I know you're probably all thinking, maybe you're not, but I hope you are. She's telling us a lot to use antipsychotic agents, but I think I've heard in the past somewhere in my training that antipsychotics might be bad in older adults because of their black box warning. And they do have a black box warning. They've had kind of a long saga with the FDA that started in 2003 with risperidone. And over the years, it has grown to encompass all of our typical and atypical antipsychotics, with the warning that there might be an increased risk of cerebrovascular disease or events, including stroke in older patients with dementia. But I want to preface that this warning came from several epidemiologic studies that were done in the outpatient setting, long-term care facilities. So really our kind of short-term, infrequent dosing of these antipsychotics in the emergency department or inpatient setting likely doesn't carry the same risk that this black box warning is warning us about.
And so just to kind of summarize some key takeaways from our didactic today, older adults are at increased risk of adverse drug events due to multiple causes, including physiologic changes, altered drug exposure, polypharmacy, prescribing cascades, and so on. So there's a need to identify older patients at high risk of adverse outcomes. We do have some tools for this, including the ISAR, doing comprehensive medication reviews, leveraging maybe our ED pharmacists and multidisciplinary teams, and doing universal or focused delirium screening, including the DTS. So pharmacologic treatment of agitation differs for pain, delirium, and dementia. So with pain, you want to start low and go slow. Delirium, it's preferred to have risperidone or haloperidol. For dementia, risperidone or olanzapine, with the caution that all antipsychotics have black box warnings, and in Parkinson's or Lewy body dementia, quetiapine is preferred. There are several medication safety programs that have been described in the ED setting that have been effective, and these involve clinical decision support tools, leveraging experts such as ED pharmacists, and providing clinician education. And then we also talked about the GEMS RX, which is the first high-risk medication list to avoid prescribing in older adults at ED discharge. All right, thank you. I think we're supposed to use the microphone. Does anybody have any questions? Hello? I don't think this is on. Hello? Okay. Does anybody have any questions?
What did you use in those scenarios?
So, so I don't actually need this. In our ED, we do have a UED geriatrics order set, and for our agitation section, we really had limited options when we first built it. So we built it based on what our inpatient order set recommended, and that was haloperidol and risperidone. And so we just recently expanded it and submitted a revision of it to really break it down by etiology. So now we have a section for patient treatment of agitation with dementia, with delirium or undifferentiated agitation, and then have all those disclaimers for Parkinson's and Lewy body dementia. And we really follow the algorithm that we presented here, so the different recommendation of the antipsychotics or possibly even the benzos in the different scenarios. And it's really to try to help the ED providers, guide them to think more about it, not just, oh, the nurse is telling me this patient's agitated and I'm just reaching for Geodon because that's what I use in my younger patients, because the literature shows that Geodon is very sedating. We're giving way too high of doses, and we're actually doing a lot of stacking in our UAB system. And so we're really trying to guide providers with a little bit more language and being able to guide them towards, appropriate medications based on the underlying etiology. And hopefully that leads to more delirium screens. Hopefully they're doing more medication reviews and doing more delirium screening as well.
So thanks for your presentation. So there are a handful of randomized controlled trials for undifferentiated agitation for all adults. I'm familiar with any geriatric agitation. So is the basis for this kind of just kind of experiences that have been published by people? Is that where this is the basis for?
Yeah, and maybe Dr. Carpenter can kind of comment on it more, but I think, was it the GRACE guidelines that came out recently? Was it GRACE for the agitation?
That was the ASAP clinical policy.
Yeah, there was an ASAP clinical policy that was recently published for agitation, but there's a big disclaimer in there that it's not like validated for older adults. And I think that there is a positive literature for the treatment of agitation in older adults, and mostly because I think the black box warning, but also the kind of the articles that we selected are fairly old, and they're not necessarily specific to the ED. So there's a lot of research that needs to be done in this area on appropriate prescribing for the treatment of acute agitation in older adults, because the current guidelines that are out there really exclude this population.
The EM literature is either excluded geriatric patients or it has such a small percentage of geriatric patients that it's not.
I guess a quick question. So like, I guess we have a lot of patients that come with like undifferentiated agitation. So what do you guys like go to in your practice? These older adults?
Yeah,
No
so-
history, we don't know.
So for undifferentiated, on this list here, and Jenny, do you want to take this question?
Sure.
She really helped revise our order sets too.
And I will preface by saying it's definitely institution specific. I think different hospitals are just using different agents, but I think one of the big questions is on this flow chart after the pain is kind of like, are they on an antipsychotic at home? So do they have a kind of underlying psychiatric condition? And I think in that case, you should definitely reach toward your antipsychotics. If they can take orals, give them their home medication. If not, then I would typically recommend olanzapine in that situation if they're not delirious, because then you need more of that dopamine blockade. I would say in most situations, if you don't need this sort of rapid sedation to get procedures and imaging, we definitely avoid benzodiazepines. We at MGH typically will avoid first-generation antipsychotics in our older adults, and so I'd say we're a pretty heavily olanzapine-forward hospital for undifferentiated agitation in these patients.
What's interesting, the atypicals, obviously, they were marketed and designed to have less EPS, but I think as they're doing, they're finding out that it probably doesn't have less EPS. So
The second generation?
the atypicals,
Yeah.
yeah. So, but I mean, the psychiatrists make a big. That's all when they do guidelines. That's what they recommend, and they basically kind of make a good trip, bad trip kind of argument. Like you think you give Haldol to someone and it's just a really bad experience, and that's generally what they tell me is the reason why they prefer atypicals from the beginning, and they'll end up on atypicals.
Yeah, what I think is interesting with the most recent kind of ASAP guidance on the treatment of agitation in the ED, a lot of the recommendations involve like combinations, so droperidol with midazolam and everything, and so I think a lot of our providers are going to start kind of reaching for these combos, which again in our older adults, not combining medications that have different kind of adverse effects is our recommendation, and I think it'll become more important in the future to kind of like differentiate these two patient populations and avoid certain combinations, even though now they're being recommended for other patients.
And that's our favorite, midazolam and droperidol. So this is interesting.
Well, thank you, everyone.